All right. So today I want to talk a little bit about bipolar. Unfortunately, I didn't get a chance to make this video last week. I kind of got a little busy, but I want to continue on with bipolar because there's some pretty big myths and misunderstandings that go along with this disease process that a lot of people don't get. So I want to clarify some things for you. First of all, bipolar is not mood swings. Let's just get that out of the way now. If you have mood swings throughout the day, I'm normal in the morning and I'm just off the wall, angry, bouncing, sad, crying, whatever. That is not bipolar. Okay. Bipolar is definite by definition. It is a general feeling of depression through most of the day or through most days, with intermixed with periods of mania, and these periods of mania can last anywhere from 5 to 7 days to 2 weeks. Um, Anything below five, we don't consider it bipolar. We consider it other things. But the mania, for those of you that don't understand what mania is it's a series of basically, if you think of bipolar being two poles, one pole being depression, you're sad, you're down, you're low. The opposite of that is way up high, and not just hey, I'm not depressed today, so woohoo, I'm happy. I can go outside and see the sun and touch grass. It's more of a you're way too up there. It's the classic signs we look for. We use the term dig fast as a acronym, but it's distractibility, impulsivity, and indiscretion. So I'm easily distracted. I can't stay focused on things. I do stuff on an impulse, on a whim. You know what? I'm gonna go buy a new car today. I'm gonna quit my job and I'm gonna go move to Hollywood and become an actor, something like that. Grandiosity. Grandiosity can come. It's delusional thought. I have seen some seriously grandiose folks. I have seen some folks that thought they were somebody who they weren't, who will literally tell you that, they were a movie star, well, and they would give the name of that movie star that they are, and they are not that movie star. Or that their, great granddaddy was, Abraham Lincoln, even though they were, you know, they immigrated from, a South Pacific island in the 1960s. Their family came over. So, there's all kinds of grandiose things you can see with grandiosity. Flight of ideas and racing thoughts. I'm not depressed and my mind's moving. I got a lot of things going. That usually gets followed by pressured speech or talkativeness, which is, if you've ever talked to me, unfortunately, you hear that a lot, which is I don't shut up. I'm kind of hard to get, to stop talking so that you can get a word in edgewise when I get rolling. But that's my norm. That's not the norm for somebody who has bipolar. That's just their norm when they get manic. Sleep deficit. And by sleep deficit, I'm not talking about insomnia. That comes with some other psychiatric diseases and mental health problems. This is more like I don't need to sleep. These are the people that are up cleaning their house at 2 o'clock in the morning, calling their friends, trying to talk, 2 o'clock, 3 o'clock in the morning. Hey, I can't sleep. Let's talk about this. Let's do that. Let's do this. Hey, what are you going to do tomorrow? That kind of stuff. And then you've got increase in activity and goal directed behavior. I know it sounds kind of vague, but it's usually things like promiscuity, um, the the cleaning the house constantly, up, down, moving. They just never sit still. Okay. Like I said, mood swings are not it. But in order to be diagnosed with bipolar, you not only have to have periods of mania and depression, you also have to have the manic symptoms in the absence of substances. So if the only time that I'm manic is when I use cocaine, probably not bipolar. I'm probably depressed and I'm treating with cocaine, and the symptoms of cocaine use or methamphetamine use or anything like that can often mimic uh, the mania of bipolar. And that is where we run into some problems during our uh, during our diagnosis. A lot of patients will come into the hospital being brought in either by the police or their family members for acting strange, acting weird, whatever, and okay, they look manic. Well, are they generally depressed? Yeah, they're not depressed today. They're definitely something else. So, right off the bat, you want to give them a bipolar diagnosis, but usually we try to test for drugs. If they come back positive for any of the stimulants, Me personally, I will not make a bipolar diagnosis based on any manic episode that you've had drugs on board at the time. Unfortunately, the way the healthcare system and insurances work in this country, a lot of hospitals can't get paid for your hospital stay if you have a diagnosis of drugs, basically. I mean, if you go into a rehab, they can, but if you're going to an actual psychiatric facility where the idea is to get you stabilized on medications and then get you back out to the streets, are you getting stabilized on medications or are you getting stabilized off of drugs? So a lot of times that diagnosis comes as a working diagnosis, if we'll call it that, so that way hospitals can keep you in longer and do a little bit of, a little bit more digging into your history and digging into what kind of psychiatric problems you actually have now that you're sober and stuff like that. Unfortunately, once you've been told you're bipolar, you're bipolar. Everybody, you're always going to tell everybody, yes, my history includes bipolar, and we kind of have to watch out for that. So that's kind of my spiels on the myths of bipolar. Just so you'll know, bipolar requires treatment. It requires medications to stabilize that mood. When I talk about mood, mania and depression are both considered moods. We want you to be nice and even keeled in the middle. We don't want you too low because that leads to suicidality and all kinds of other social problems and self esteem problems. Um, and we don't want you manic because unfortunately, mania leads to problems with relationships, problems with job and finances, problems with the law, and it tends to get you in the hospital a lot. So we we tend to treat those problems with medications that we call mood stabilizers or antipsychotics because they tend to work well as mood stabilizers. Um, on a side note, one of the other types of medicines we use are epileptic medications like Depakote and Trileptal, things like that. They tend to stabilize mood very well. And the classic mood stabilizer that we think of in psychiatry is lithium. And piece of trivia on lithium: the way they found out that lithium worked as a mood stabilizer was that people in Europe who lived in places where their groundwater or their water source had a high concentration of lithium in it tended to be less depressed and show less mood symptoms. So we don't know why it works, but it works. So it comes with some drawbacks, as does every medication, but it is kind of the gold standard when it comes to medications for bipolar. I know this ran a little long. I appreciate you guys listening to it. Hope you learned something out of it. And yeah, have a good day.